Our next speaker is Gwen Darien of the National Patient Advocate Foundation. Ms. Darien is Executive Vice President for Patient Advocacy and Engagement, and she leads programs that link the Foundation's patient service programs to their initiatives. She's also Chair of Community Engagement in the Genomics Working Group of the National Human Genome Research Institute and co-chair of the Patient-Centered Outcome Research Institute Patient Engagement Advisory Panel, and we're so glad that you could join us today.
Thank you very much. Thank you for inviting me. Can you hear me? Am I on? Okay, great. I'm also going to start my timer because I have a tendency to sometimes be a little wordy. And I have no slides. So I've had PowerPoint fatigue much longer than I've had Zoom fatigue. And so I have no slides. I just have my outline next to me of indecipherable notes. I am so grateful to be part of this conversation for many reasons. I mean, I think that just to give you all a little background, the Patient Advocate Foundation works to increase and ensure access to quality, equitable, affordable care to people who are facing serious, life-threatening, and debilitating illnesses, chronic illnesses. We do not primarily work with people who are in the primary care system, but we work with people who have been put into the serious illness system, hopefully coming through the primary care system. And that was one of the things I wanted to address today. So I wanted to talk about, first of all, one of the things I wanted to do is just, as an advocate, as a health advocate, I've been an advocate for almost 25 years now since my first diagnosis of cancer. So I am a 3-time cancer survivor. I have a personal lens, and I also have the lens of somebody who's been working in health advocacy for a very long time. But one of the things that is the most important thing I think that I've done and my colleagues have done as health advocates is make explicit what has always been, what is often implicit. And I think if we started this panel today without acknowledging the situation that we're in and the situation that our country is in, we are not making explicit some of the really significant barriers to people's health and to people's care. We are in the midst of a pandemic that has disproportionately affected people of color, that's disproportionately affected underserved and vulnerable populations. And we're also in a time where the roots of these social inequities are being expressed in racism, the structural racism in this country, by protests around the country. I think the other thing that I want to make sure that we talk about is that we assume access to care. And one of the things that the pandemic is showing us, and one of the effects of the pandemic, is that access to care certainly has never been able to be taken for granted, but it is even more of an emergency and even more of a crisis now, where 25% of the working population is unemployed. And most of us, many of us, particularly those of us who are not Medicare age, get our insurance through our work. So what happens to those 25% of the public who is not working? How do they have access to care? Then on the other side, we have primary care practices whose sustainability is threatened by the pandemic and the changing economic upheaval. So I wanted to put those couple of points forward as something that I think we have to explicitly look at, particularly as we're looking at recommendations going forward. When the definition was written, it was written in 1996. It was a very different time. And my comments are really going to be looking through the lens of two things that are the most important to our patient population, which are trust and access. And for that to happen, there has to be, we have to look at the primacy of relationships. And one of the things I think about when I think about primary care is the primacy of the relationship, and the primacy of the relationship with our healthcare providers, whether it is, I think it's also very fair to say, and I want to echo previous speakers that healthcare relationships used to just be doctors and patients, but that is, we have certainly gone well beyond doctors and patients in our healthcare relationships. But we do not, we must put that in the forefront and think about what it means to have that kind of trusting relationship, what it means to have a relationship where you have a primary care provider who really is the center of your care and really is the provider of and the person who coordinates that care. And I think we have a significant lack of coordination. I also wanted to say that there is our colleagues at Public Agenda have we've been doing a lot of work around trust, and our colleagues at Public Agenda have a project coming out in September on the primary care and trust and the Medicaid population. So I would just encourage you to look at that as you're looking at your recommendations. But what I did when I was thinking about what I would say today is I looked at the different parts of the definition of primary care that was written in 1996. So and I pulled out a few of the words. I'm a word person too. I love looking at words, and words have very significant meaning. So first I looked at integrated. And most of the patients that we serve, since we're supposed to give the lens of the patients we serve, first of all, they're lower income. The average household income is below $35,000. And the way that they experience care is incredibly fragmented. Integrated is not something that people experience who come to us, because if their care was integrated, their access to care would be much easier, and the issues that they face, which are many of them are around cost, but not just cost of medical care, but the cost of opportunity costs and the cost of living and everything that goes around our healthcare system, as we've talked about before, social risk, social determinants of health. They don't experience integrated care. So I think that is a hugely, that is a critical goal for primary care. But it is a goal that we have to look at how we're going to deal with integrated care, because that is not the way people experience the healthcare system. It's also not the way I experienced the healthcare system, my first diagnosis of cancer. So I will, I was employed, insured, working in the arts. I was 35 years old, and my primary care physician, I had a very poor, very fragmented care that was, I think, led to a lot of the issues, and led to me being an advocate and being a health advocate, because as we know, many people start from an experience of their own or an experience of their family or friends. We also look at accessible. I looked at accessible, I pulled that out because accessible is something that we can't just assume that healthcare is accessible. We have to look at the roots of what makes it inaccessible. And we also have to look at how we address those roots sort of one by one. So I mentioned cost barriers, but cost barriers are not just cost of medical care. It is the cost of daily living. We have people call us who are not able to, they're cutting their pills in half, they're skipping their medication, they are not going to the doctor because they can't afford, or the nurse practitioner because they can't afford parking. They go to the pharmacist, they walk away from the prescription because their copay is $1,000, and they had no idea it was going to be $1,000, and who has $1,000 in their pocket? What is the statistic? Most American families don't even have $300 in there to deal with an emergency. So we're talking about really significant and really systemic access barriers that we also have to address in primary care, and I think primary care is a place to address those. There are many, many resources out there, and it's really important that everybody has those resources. The other thing that I pulled out was accountability. And one of the things that we've thought about a lot in terms of trust is that trust is bidirectional. So it's not enough. There's been a lot of work on on talking about why patients have to trust their providers and the healthcare system, but there's not a whole lot of conversation and not a whole lot of data around why physicians have to trust their patient, and how that breakdown of physician trust of patients is key to is really one of the primary factors of the breakdown in this relationship. And that's one of the things that's addressed in this public agenda report. But when I think about accountable, I think about what we're really working towards, which is a co-created care plan, a co-created accountability and a bidirectional accountability, where by creating a plan together, patients and their health care providers are both accountable for their care. And then sustained partnership. This is one of the things that happens so often with people with serious illness, that they get into the specialist system and there's no care transition back into the primary care. There was a comment about follow-up and about continued relationships. And I think people with serious illnesses, debilitating illnesses, are often they're often not reintegrated into the primary care relationship. And I think that's a really, really critical point. So in terms of my recommendations, I think I've made many of them, but I think one of the things that was glaringly missing from this definition was equity. And in order to have a definition of primary care that I think is a definition that we need to have, and also will change the health of this country, we have to put access to equitable care, not just access to care. So thank you very much for listening to me without slides, and thank you very much for inviting me to this conversation. And I look forward to the Q&A.